Usually when we talk about a medical diagnosis, there's this expectation of like precision. It feels almost like engineering.
Right, very mechanical.
Exactly. Like you break your arm, the x-ray shows that jagged white line, and the doctor points to the film and just says, there it is. That's the problem. And here's the cast that fixes it.
Yeah, it's very binary. Clean.
It is. We really like things to be visible and perfectly categorized, but then you step into the world of chronic cardiovascular disease, specifically heart failure, and suddenly that x-ray machine is just completely useless. We're looking at a diagnostic and therapeutic landscape that is incredibly murky.
Oh, it is the absolute definition of diagnostic muddy waters. And the stakes in those waters, I mean, they couldn't be higher. We're not just talking about some mild inconvenience here.
No, definitely not.
We're talking about a systemic collapse of the body's central pump.
Mm.
The raw numbers from our source text for this deep dive are just staggering. In the U.S. alone, heart failure currently affects 6.2 million people.
Yeah, and the statistic that always just stops me in my tracks when I'm, at the bedside or teaching clinicals is the mortality rate. We are looking at a 50% mortality rate within 5 years of the initial diagnosis.
Half of all patients.
Gone. Within 5 years. That is a mortality rate that actually rivals and a lot of specific demographics exceeds several major aggressive cancers.
Yeah, which is terrifying when you frame it like that.
Right. We treat cancer with this incredible urgency, yet heart failure, it often gets treated as this sort of slow, inevitable decline. And the economic burden follows that exact same overwhelming trajectory. I mean, we're looking at nearly $31 billion in healthcare expenditures annually right now.
And the projections show that hitting almost $70 billion by 2030.
It's just a slow-moving tidal wave.
Which really means we need a fundamental shift in how we understand and manage this disease.
Yeah.
We've moved far, far past the days of simply giving a patient a water pill and just, hoping for the best.
Thank goodness.
Yeah, the contemporary pharmacological management of left ventricular systolic dysfunction is, well, it's one of those complex, elegant, and honestly, sometimes dangerous areas of modern medicine.
Oh, absolutely.
It
Right.
requires this really deep understanding of pharmacokinetics, microscopic mechanisms of action, and crucially, the safety guardrails that keep these really powerful neurohormonal modulators from doing profound harm.
So whether you are a healthcare student prepping for your pharmacology boards, or maybe a practicing clinician looking to update your understanding of the latest guidelines, or, just someone who is fiercely curious about how we can chemically manipulate human physiology to save a failing organ, we are bringing you on clinical rounds with us today.
Yes, we are.
We're going to completely deconstruct the failing heart. We want to answer this one central question. How do we go from treating heart failure as a simple plumbing problem to realizing it is actually this complex neurohormonal civil war happening inside the body?
To answer that, we really have to start at the mechanical level. I mean, before we can start introducing the chemical weapons we use to fight this war, we have to understand the battlefield itself.
Right, exactly.
The text defines decompensation as the inability of the heart to adequately circulate oxygenated blood to the body's vital organs to meet their metabolic needs. So that concept of supply and demand, that's the cornerstone.
The baseline.
Yeah, the body demands a certain amount of oxygen and nutrients just to maintain baseline homeostasis. When the heart cannot supply that baseline demand, it is decompensated.
And there are just a multitude of culprits that can push a heart to that point of decompensation, right? It's rarely a single catastrophic event out of nowhere. It's usually a compounding series of insults over time.
Absolutely.
So let's walk through the major contributors, starting with probably the most ubiquitous one, hypertension. High blood pressure.
Yeah, hypertension. If we look at that through the lens of physics, it's really a problem of systemic vascular resistance. The arteries are constricted, the pressure is high. It's akin to trying to blow a really thick milkshake through a very narrow, rigid cocktail straw.
Oh, that's a great analogy.
Right. The left ventricle has to generate a massive amount of force to overcome that increased resistance, which we call afterload, just to get the aortic valve open and push the blood out into the systemic circulation.
And day after day, year after year, that muscle is just working against a brick wall. Like any muscle you constantly overwork, it hypertrophies. The ventricular wall physically thickens to handle the stress.
But cardiac muscle isn't like skeletal muscle.
Yeah.
Bigger isn't always better.
Right, because that thickened muscle requires way more oxygen, it becomes stiffer, and eventually the structural integrity just gives out. The muscle becomes exhausted, it dilates, and it begins to weaken and fail.
Exactly. Yeah. Then you layer coronary artery disease, or CAD, on top of that.
Yeah.
Now, CAD is a primary supply issue to the heart muscle itself. The coronary arteries, the ones that wrap around the outside of the heart and feed the myocardium, they get narrowed by atherosclerotic plaque.
So less blood gets through.
Yeah, and when you combine that reduced blood flow with an increased demand, like maybe the patient is exercising or they're just under severe physiological stress, the heart muscle experiences ischemia. It is quite literally starving for oxygen.
And that starvation damages the myocardium. If the ischemia is severe enough and prolonged enough, tissue dies. And closely related to CAD is the whole concept of coronary artery endothelial dysfunction, right?
Yeah, the endothelium.
The inner lining of the blood vessels. It basically stops producing vasodilators like nitric oxide. The lumen narrows, blood flow drops, and that damaged lining can so easily trigger the formation of a thrombus, a blood clot.
And if that clot completely occludes the artery,
Boom! Massive myocardial infarction. A heart attack. The tissue downstream of that clot undergoes necrosis, turns into scar tissue, and, well, scar tissue cannot contract, it can't pump. You have permanently lost a percentage of your ejection capacity right there.
it's rough. And the diversity of these underlying causes is what makes diagnosis so challenging. It's not just plumbing issues or dead tissue. Cardiac dysrhythmias can independently drive a heart into failure.
Because it's an electrical issue then.
Right. The heart relies on a perfectly synchronized electrical cascade to achieve a coordinated mechanical squeeze. If the electrical system is chaotic, say, in sustained, rapid atrial fibrillation, the mechanical pumping is chaotic too. The ventricles just don't have adequate time to fill with blood during diastole, and the contraction is totally disorganized.
The heart is beating incredibly fast, but it's effectively pumping nothing.
Exactly. We also see mechanical barriers, specifically heart valve disorders. The valves are basically the doors that keep blood moving in one direction.
Right, so if a patient has aortic stenosis, the valve is calcified, it's stiff, it's narrow. The left ventricle has to generate enormous pressure just to force blood through that tiny little opening.
And conversely, if they have mitral regurgitation, the valve is floppy.
Right. So every time the ventricle squeezes to send blood forward into the aorta, a large portion of that blood just shoots backward into the left atrium. The forward flow is severely compromised, and the heart has to work overtime to compensate for that massive inefficiency.
We also cannot ignore the systemic issues that act as massive external stressors on the cardiovascular system. Fluid volume overload is a primary trigger for acute decompensation. If a patient has underlying chronic kidney disease, their nephrons cannot adequately filter and excrete fluid.
So the circulatory system just gets engorged.
Yeah. The heart, which might already be slightly weak, is suddenly presented with this massive, overwhelming volume of fluid returning to the right atrium. It simply cannot keep up with the volume.
And, this is where we really need to look in the mirror because as healthcare providers, we frequently cause this fluid overload iatrogenically.
Oh, absolutely.
We can accidentally tip a stable patient right into acute heart failure with overly aggressive IV fluids or rapid blood transfusions. But honestly, even more common is the everyday pharmacology we prescribe for completely unrelated conditions. Things like corticosteroids, estrogens, and particularly NSAIDs, nonsteroidal anti-inflammatory drugs like ibuprofen, naproxen, celecoxib.
The NSA dynamic is a perfect example of competing physiological priorities. When a patient takes a high-dose NSAID for, say, chronic joint pain, that drug blocks the production of prostaglandins.
Which we need.
Very much so. Prostaglandins are crucial for maintaining vasodilation in the afferent arteriole of the kidney. When you block them, the blood vessel feeding the kidney constricts. Renal blood flow drops, the glomerular filtration rate plummets, and the kidney immediately signals the body to retain sodium and water to try and boost the pressure.
So a patient taking heavy doses of ibuprofen for a bad knee is actively forcing their kidneys to hoard water. The intravascular volume expands dramatically, increasing the preload on the heart. I have seen so many patients admitted for acute heart failure exacerbations. And when we do the medication reconciliation, the culprit wasn't a missed cardiac pill. It was the fact that they started taking an over-the-counter NSAI around the clock a week ago.
Yep, happens all the time. The pharmacology of other systems constantly intersects with the heart. We see a similar profound impact with thyroid disorders, too. Hyperthyroidism creates a systemic hypermetabolic state. The entire body is in overdrive. The sympathetic nervous system is heavily upregulated.
Heart rate spikes.
The resting heart rate spikes, myocardial contractility increases, and the required cardiac output skyrockets just to meet the massive metabolic demand of the tissues. The heart literally runs itself into the ground, leading to what we call high-output heart failure.
And the inverse is equally damaging, right? Hypothyroidism. The hypometabolic state negatively impacts the heart because the myocardial tissue lacks the essential thyroid hormones it needs for normal gene expression and protein synthesis.
The contraction becomes sluggish.
Yeah, and furthermore, hypothyroidism is a massive driver for hyperlipidemia and obesity, which just accelerates the atherosclerotic plaque buildup, circling right back to cause coronary artery disease. It is just this vicious, interconnected web of pathology.
So we've established the underlying insults, the why the heart fails.
Hmm.
But to really understand the pharmacology, we need to look closely at the how. How is the left ventricle actually malfunctioning mechanically?
Right.
This brings us to the crucial diagnostic distinction between the two distinct phenotypes of left-sided heart failure, HFrEF and HFpEF.
These acronyms are literally everywhere in the clinical guidelines. Let's break down HFrEF first.
Sure. HFrEF stands for heart failure with reduced ejection fraction. This is the classic presentation of systolic heart failure. To understand this, we need to clearly define ejection fraction, or EF. The ES is the percentage of the total amount of blood inside the left ventricle at the end of diastole that actually gets pumped out into the aorta with each single systolic contraction. A normal, healthy left ventricle never empties completely,
Yeah.
A normal EF is usually between 55 and 70%.
The heart always keeps a little reserve volume inside.
Correct. But in HFrEF, the ejection fraction drops to 40% or less. The actual muscular wall of the left ventricle has lost its fundamental ability to contract with sufficient force. The systolic squeeze is just weak, sluggish, and totally inadequate.
When I'm trying to visualize this or, explain it to a patient, the analogy I always come back to is a stretched out, worn out rubber band.
Oh, I like that.
Think about a rubber band you find at the bottom of a desk drawer that's been sitting there for 10 years. You stretch it out and it just sags. It has completely lost its snap. In HFrEF, the heart muscle is that flabby, weak rubber band. The ventricle dilates and fills with blood just fine. In fact, it often overfills because it's so stretched out. But when the electrical signal tells it to squeeze, it simply cannot snap back tightly enough to eject that blood forward. The forward velocity is just gone.
That is a perfect visualization of systolic dysfunction. The volume is there, but
Yeah.
the power is gone. Now, contrast that with the other phenotype, HFpEF, which is heart failure, with preserved ejection fraction.
Right, the preserved one.
This is diastolic heart failure. In this scenario, you look at the echocardiogram, and the ejection fraction is perfectly normal. It might be sitting at a healthy 60%.
Right.
But the patient is still in profound symptomatic heart failure.
And this is the concept that always trips people up. If the pump is successfully ejecting 60% of its volume, which is a passing grade, why are they in heart failure?
Because the denominator of that equation has changed drastically. The total volume capacity of the ventricle has shrunk. In HFpEF, the left ventricle becomes highly hypertrophied. The walls are thick, fibrotic, and incredibly stiff. Because of this stiffness, the ventricle loses its ability to relax and expand during diastole.
So it can't stretch to accept the incoming blood?
Precisely.
Oh.
Because it cannot relax, it cannot properly fill with blood from the left atrium. So sure, the muscle is still strong enough to pump out 60% of whatever is inside it. But if it only filled with a tiny, inadequate amount of blood to begin with, 60% of a tiny amount yields a dangerously low total cardiac output. The preload, the end-diastolic volume that stretches the ventricle before contraction, is severely restricted.
Sticking with the analogies, if HFrEF is the weak, flabby rubber band, HFpEF is like a thick, stiff leather pouch. You try to pour a cup of water into it, but the leather is so rigid and inflexible that it will not open up to let the water inside. The water just hits the opening and immediately overflows backward.
And that concept of overflowing backward is the perfect segue to the clinical manifestations. Because regardless of whether the primary mechanical problem is a weak systolic squeeze or a stiff diastolic filling chamber, the end physiological result for the patient is essentially the same.
Inadequate forward cardiac output to the body and massive fluid congestion backing up behind the failing pump.
Exactly.
Let's talk about what that actually looks like when we walk into a patient's room. The cardinal manifestations of heart failure are directly tied to those two directional failures. The lack of forward flow means the peripheral tissues, the skeletal muscles, the brain, the kidneys, they're not getting enough oxygenated blood.
So they feel awful.
The patient experiences severe, debilitating fatigue, profound weakness, a massive drop in exercise intolerance. Tasks that used to be simple, walking to the mailbox, carrying a load of laundry, even just taking a shower, suddenly feel like running a marathon at high altitude.
Yeah, the metabolic demand of those simple tasks outpaces the heart's ability to supply oxygen, leading to rapid lactic acid buildup in the muscles and just profound exhaustion.
And then there's the dyspnea, the shortness of breath, which brings us to the phenomenon of backward failure. If the left ventricle cannot pump blood forward efficiently into the aorta, that blood doesn't just magically disappear. It acts like a massive traffic jam on a highway. The blood backs up into the left atrium.
Right.
And as the left atrium distends, the pressure backs up into the pulmonary veins, which are the vessels carrying oxygenated blood from the lungs back to the heart.
The pressure in that closed pulmonary venous system steadily and relentlessly increases.
And as that hydrostatic pressure builds inside the tiny, fragile pulmonary capillaries, it physically forces the fluid component of the blood, the plasma, out of the vascular space and into the interstitial tissue of the lungs, and eventually straight into the alveoli. The patient is literally mechanically drowning in their own transudative fluid. We call this pulmonary edema.
It's a terrifying state to be in.
When you place a stethoscope on their back and ask them to take a deep breath, instead of hearing clear air movement, you hear these wet, bubbling, crackling sounds called rails or crackles. The air is physically popping through a layer of fluid.
This specific hydrostatic pressure dynamic gives rise to one of the most classic telltale symptoms of decompensated heart failure, orthopnea.
Oh man, orthopnea is a fascinating, if terrifying, mechanical process to observe. It's defined as a patient experiencing severe shortness of breath, specifically when they lie flat.
The mechanics of it are purely driven by gravity and fluid shifts, right?
Exactly. During the day, when the patient is standing or sitting upright in a chair, gravity pulls their total fluid volume downward. Because the failing heart is already struggling to maintain venous return, that high venous pressure causes fluid to leak out of the vascular system and pool in the interstitial spaces of the lower extremities. We call this third spacing. You look at their legs, and they have severe peripheral edema. Their ankles are swollen, their calves are tight and shiny.
The fluid is trapped in the dependent areas.
But then, night comes. The patient gets into bed and lies perfectly flat. Suddenly, the gravitational force that was trapping all that fluid in their legs is neutralized. All of that third space fluid in the lower extremities begins to mobilize. It shifts back out of the tissues into the intravascular venous space and rushes straight back up the inferior vena cava to the right side of the heart.
That's a lot of fluid all at once.
A ton of it. The right ventricle pumps this massive influx of volume into the pulmonary circulation, which then dumps it directly into the left atrium and the already failing left ventricle.
And the left ventricle, which was barely managing to pump the baseline volume during the day, is suddenly utterly overwhelmed by this massive, rapid tidal wave of returning fluid volume. The end diastolic pressure spikes exponentially. That pressure is transmitted instantly backward into the pulmonary capillaries, the fluid gets shoved violently into the alveoli, and the patient wakes up 2 hours after going to sleep, sitting bolt upright on the edge of the bed, gasping for air, feeling like they're suffocating.
This is a condition called paroxysmal nocturnal dyspnea, or PND. It's why, when taking a history from a cardiac patient, we always ask, how many pillows do you sleep on at night?
Such a vital question.
If a patient says they used to sleep flat on one pillow, but over the last month they've had to stack 3 pillows behind their back, or they've given up on the bed entirely and have to sleep completely upright in a recliner just to keep the fluid out of their lungs, that is a massive screaming red flag that their heart failure is actively decompensating.
And if we follow the pathophysiology further, over time, this chronic left-sided failure and constant pulmonary congestion will inevitably cause the right side of the heart to fail as well.
It's a domino effect.
Yeah. The right ventricle is normally a low-pressure pump. Its only job is to push blood through the delicate, low-resistant, spongy tissue of the lungs. But now those lungs are stiff, engorged with fluid, and the pulmonary artery pressure is incredibly high. The right ventricle has to pump against all that high pressure. It eventually exhausts itself and fails. When the right side fails, blood backs up into the systemic venous system. That's when you see the distended jugular veins bulging in the neck. Massive weight gain from profound fluid retention in the abdomen causing ascites, and even more severe, weeping peripheral edema.
It's a devastating, relentless cascade. The left side fails, drowning the lungs, which forces the right side to fail, drowning the rest of the body. Which brings us to the critical inflection point of this deep dive. Now that we can clearly see the fluid overload, understand the mechanical difference between HFrEF and HFpEF, and trace the cascade of failure, how do we intervene? How do we stop this from happening? We have to move beyond just trying to treat the symptoms. We need to look at the core of guideline-directed medical therapy, or GDMT.
Right, the evolution of GDMT represents a complete paradigm shift in cardiovascular pharmacology. Historically, the approach was largely symptomatic and mechanical. If the patient had too much fluid, we gave them a massive dose of a diuretic to force them to urinate. If the heart was beating weakly, we gave them a drug like digoxin to force the muscle to squeeze harder.
Yeah.
It was purely about manipulating the plumbing.
But modern GDMT is entirely different.
Oh, completely.
Yeah.
The primary goal of pharmacologic management now is to intervene at the cellular level to slow, halt, or ideally completely reverse the progression of the myocardial dysfunction.
Because we recognize that the mechanical failure was just the trigger. The real damage, the reason the mortality rate is 50% is because of the body's own neurohormonal response. The body is actually its own worst enemy in heart failure.
It really is.
When cardiac output initially drops, the baroreceptors in the blood vessels sense that the blood pressure is low. The brain panics. It thinks the body is bleeding out or in profound shock. So it activates its two most powerful survival mechanisms, the sympathetic nervous system and the renin-angiotensin-aldosterone system, or the RAAS.
Heavy hitters.
It dumps adrenaline into the bloodstream to whip the heart into beating faster. It clamps down on the peripheral blood vessels to artificially prop up the blood pressure. And it tells the kidneys to hold on to every single drop of sodium and water it can find to boost the circulatory volume.
And in the context of a healthy heart dealing with acute blood loss from a trauma, those mechanisms absolutely save your life. But in the context of a failing, overloaded heart, it is the absolute worst possible biological response.
You're forcing a weak, exhausted pump to push against severely constricted blood vessels,
Massively increasing the afterload. And you are simultaneously dumping gallons of retained fluid back into it, massively increasing the preload. The neurohormonal compensation literally strangles the heart to death. So, modern GDMT is specifically designed to block these harmful maladaptive neurohormonal pathways. Our goals are to improve the patient's daily symptoms, certainly, but the primary endpoints we are chasing are reducing mortality and preventing those repeated, progressive, physically devastating hospitalizations.
And the absolute star of the show right now, the drug class that has completely rewritten the preferred first-line therapy guidelines for symptomatic heart failure with reduced ejection fraction, is the ARNI, the angiotensin receptor neprilysin inhibitors, specifically the prototype drug sacubitril/valsartan, which most people know by the brand name Entresto.
What's fascinating here is the pharmacology of the ARNI is a masterpiece of targeted biochemical engineering. Sacubitril/valsartan is not a single molecule, it's a supramolecular complex.
Like two drugs in a trench coat.
Pretty much. It is actually two completely different drugs, sacubitril and valsartan, combined in a 1-to-1 molar ratio into a single crystalline complex. Let's break down the mechanism of each half, because they act on opposing sides of the neurohormonal civil war. We'll start with the novel component, the neprilysin inhibitor, sacubitril.
At the bedside, we know the body isn't entirely defenseless. When the heart muscle is stretched and distended by all that excess fluid volume returning to the ventricles, the myocardial cells physically stretch. That mechanical stretching triggers the release of peptides, specifically B-type natriuretic peptide, or BNP. These natriuretic peptides are the body's natural, built-in defense mechanism against heart failure.
They are profoundly beneficial. When circulating natriuretic peptides bind to their receptors on blood vessels, they promote potent vasodilation, opening up the arterial bed and dropping the afterload. Simultaneously, when they reach the kidneys, they promote natriuresis, the active excretion of sodium into the urine, which drags water right along with it.
So they decrease blood pressure, decrease sympathetic tone, and decrease aldosterone levels. They are the exact antidote the failing heart needs.
Exactly.
So logically, we want massive amounts of these natriuretic peptides floating around in the bloodstream. We want them constantly opening the vessels and clearing the fluid.
We do. But the human body relies on constant feedback loops to maintain equilibrium. It does not allow any hormone to circulate indefinitely. The body produces an endogenous enzyme called neprilysin, and neprilysin's primary physiological job is to hunt down, cleave, and rapidly degrade those beneficial natriuretic peptides, clearing them from the circulation.
In the context of heart failure, neprilysin is actively destroying the only endogenous chemicals trying to save the heart. It's basically the bad guy.
It is the bad guy. So the sacubitril half the Entresto complex is a targeted neprilysin inhibitor. By chemically blocking the neprilysin enzyme, we stop the continuous destruction of the natriuretic peptides. The half-life of those beneficial peptides extends dramatically. Their concentrations rise in the blood, leading to sustained, powerful vasodilation and continuous diuresis. We're amplifying the body's own natural rescue mechanism.
The logic there is flawless. We stop the enzyme that kills the good peptides. But if sacubitril is so incredibly effective at boosting these natural vasodilators, why do we need the second half of the drug? Why add the valsartan? Why not just manufacture a pill that only contains sacubitril?
That is the exact question the initial researchers faced, and the answer lies in the frustrating lack of specificity in enzyme pathways. Neprilysin is a promiscuous enzyme. It doesn't solely degrade natriuretic peptides. It is also one of the primary enzymes responsible for breaking down and degrading angiotensin II.
Wait, angiotensin II, that is the final, potent end product of the RAAS pathway. Angiotensin II is a chemical that violently clamps blood vessels shut, triggering the release of aldosterone from the adrenal glands to hold on to salt and water, and directly driving the formation of fibrotic scar tissue in the heart. Angiotensin II is the primary driver of the neurohormonal toxicity we're trying to stop.
Precisely. It is the ultimate enemy of the failing heart. So imagine what happens if you give a patient sacubitril alone. You successfully inhibit neprilysin, and your good natriuretic peptides go up. But because neprilysin is no longer there to break down angiotensin II, the levels of harmful angiotensin II also skyrocket simultaneously.
Oh no.
Yeah, the massive increase in vasoconstriction from the angiotensin II completely overpowers the vasodilatory benefits of the natriuretic peptides. You trade one problem for a significantly more lethal one.
It's an incredible biochemical catch-22. So that's exactly why the sacubitril has to be permanently coupled with valsartan.
Yes. Valsartan is an angiotensin II receptor blocker, an ARB. Its mechanism is highly specific. It travels to the smooth muscle of the blood vessels and the adrenal glands, and it physically sits on the AT1 receptors, completely blocking them. It doesn't stop the body from making angiotensin II, but it completely prevents that circulating angiotensin II from binding and exerting any harmful effects.
It's an incredibly elegant trap. The sacubitril throws a wrench in the enzyme system to stop the breakdown of the good peptides. And because that accidentally stops the breakdown of the bad angiotensin II, the valsartan acts as an impenetrable shield, blocking that excess angiotensin II from actually causing any vasoconstriction or fibrosis. It's simultaneous dual-action manipulation of two opposing neurohormonal systems. We boost the good, and we block the bad.
And from a pharmacokinetic and pharmacodynamic standpoint, the delivery system is also quite robust. Sacubitril itself is actually a prodrug.
Meaning when the patient swallows the pill, the sacubitril is completely biologically inactive.
Correct. It is heavily protein-bound in the blood plasma, primarily to albumin. It must pass through the liver, where specific esterase enzymes cleave it into its active metabolite, sacubitril. Because of the pharmacokinetics of both components, the drug requires twice-daily dosing. When a patient starts therapy, the steady-state plasma concentrations of both the active sacubitril and the valsartan are achieved in roughly 3 days.
Fast working.
Very fast. And the clinical outcomes generated by this dual mechanism are undeniable. In massive randomized controlled trials, the ARNI demonstrated a highly significant, unprecedented reduction in the risk of cardiovascular death and heart failure hospitalization compared to our older gold standard therapies like ACE inhibitors. It fundamentally altered the mortality curve.
But as with any powerful pharmacological tool that manipulates systemic hormones, there are massive, non-negotiable safety guardrails. As a nursing educator, this is where my alarms start ringing, because a medication administration error with an ARNI doesn't just cause a mild side effect, it can be rapidly fatal. We have to talk about the 36-hour washout period.
This is arguably the most critical safety protocol for anyone prescribing, dispensing, or administering these drugs.
Here's the incredibly common clinical scenario. A patient comes into the clinic. They've been managing their heart failure for 5 years on an older drug class, an ACE inhibitor, something like lisinopril or enalapril. The guidelines have updated and the provider says, we need to upgrade you to the ARNI. It's superior therapy. Let's switch you to Entresto. You absolutely cannot just tell the patient to stop taking their lisinopril on Monday morning and take their first dose of Entresto on Monday night.
No, you cannot.
You must wait a minimum, absolute strict minimum, of 36 hours between the very last swallowed dose of the ACE inhibitor and the very first dose of the ARNI. Why is that specific, prolonged washout period so vitally important?
It comes down to the accumulation of a specific vasoactive peptide called bradykinin. Bradykinin is a powerful substance produced by the body that causes profound vasodilation and, crucially, a massive increase in localized vascular permeability. It physically alters the tight junctions between the endothelial cells lining the blood vessels, making the capillaries incredibly leaky.
Okay, leaky vessels.
Normally, the body keeps bradykinin levels perfectly balanced because the angiotensin-converting enzyme, or ACE, acts as one of the primary cleanup crews, constantly breaking down excess bradykinin. So if a patient is taking an ACE inhibitor, they are deliberately blocking that breakdown pathway. Their baseline bradykinin levels naturally rise. This mild chronic elevation of bradykinin in the pulmonary tract is actually what causes the classic, annoying, dry hacking cough that forces so many patients to stop taking ACE inhibitors.
Right, the persistent ACE cough. It's a hallmark side effect.
But remember, our discussion about neprilysin's lack of specificity. Neprilysin doesn't just degrade natriuretic peptides in angiotensin II. Neprilysin is the other major enzyme pathway responsible for breaking down bradykinin.
Oh, I see where this is going.
So if a patient still has an active ACE inhibitor circulating in their system, they have completely blocked the first major bradykinin breakdown pathway. If you then immediately introduce sacubitril, you completely block the neprilysin pathway, the second major breakdown pathway.
You have entirely eliminated the body's ability to clear bradykinin from the blood.
Precisely. Without any active degradation enzymes, the circulating bradykinin levels skyrocket exponentially in a matter of hours. And because bradykinin makes blood vessels incredibly leaky, all of that intravascular fluid rapidly rushes out of the capillaries and floods into the surrounding subcutaneous tissues and submucosal layers, causing massive, rapid, disfiguring swelling. This is the clinical definition of angioedema.
And I cannot stress enough to students that angioedema is not just a puffy face or swollen eyelids. It's not an allergic reaction you can just fix with some Benadryl. Angioedema frequently targets the mucosal tissues of the lips, the tongue, the pharynx, and the larynx. The tissues in the throat and airway swell up so fast and become so engorged with fluid that they physically impinge on the trachea.
It's an immediate emergency.
It causes complete, irreversible airway obstruction. The patient cannot move air, they can asphyxiate and die before the emergency response team can even attempt to force an endotracheal breathing tube past the swollen vocal cords. That 36-hour washout period is not a suggestion. It's the physiological time required for the ACE inhibitor to completely clear the system and unblock that first pathway so you do not trigger that massive fatal bradykinin spike when you introduce the ARNI.
And while we're discussing the life-threatening risk of angioedema, we must explicitly highlight a critical quality and safety alert detailed in the text. Black patients are at a statistically higher risk of developing angioedema with the administration of sacubitril/valsartan compared to other demographic groups. This physiological difference requires heightened vigilance from the clinical team and incredibly comprehensive, specific patient education before they're discharged.
When I'm doing discharge teaching, I tell patients, if you feel a tingling sensation in your lips, if your tongue feels inexplicably thick or heavy, or if you feel a strange fullness in the back of your throat, you do not wait to see if it gets better. You do not call the clinic to leave a message. You call 911 or go to the nearest emergency room immediately. It is a catastrophic medical emergency.
Absolutely. The speed of onset can be terrifying. Another critical, absolute, non-negotiable safety consideration with the ARN class, and truly any drug interacting with the RAAS, involves pregnancy.
Right. There is a prominent, strict black box warning across the entire class. Any drug that acts directly to inhibit the RAAS pathway, which includes the valsartan component of the ARNI, as well as all isolated ACE inhibitors and ARBs, can cause profound, irreversible injury and death to the developing fetus, particularly if administered during the second and third trimesters.
The pathophysiology behind the teratogenicity is fascinating, really. The fetal renin-angiotensin-aldosterone system isn't just managing blood pressure. It's actually a vital signaling pathway required for normal fetal organogenesis, specifically the development and maturation of fetal kidneys. If a pregnant patient takes an ARNI, the drug crosses the placenta and completely blocks the fetal RAAS. Without that signaling, the fetal kidneys fail to develop properly and cease functioning.
The fetus stops producing urine.
Correct. And fetal urine is the primary component of amniotic fluid in the second half of pregnancy. The lack of urine production leads to severe oligohydramnios, critically low levels of amniotic fluid. Because the fetus is no longer suspended in a buoyant fluid environment, it is subject to the continuous compressive forces of the uterus. This mechanical compression causes severe skeletal deformities of the skull and limbs. Furthermore, without adequate amniotic fluid to breathe in and out, the fetal lungs cannot expand, leading to lethal pulmonary hypoplasia. The lungs simply do not grow. It frequently culminates in fetal death or severe neonatal morbidity.
So the nursing instruction is black and white with zero room for interpretation. Individuals of childbearing potential must use highly effective, reliable contraception while taking these medications. If pregnancy is detected or even suspected, the ARNI must be discontinued as soon as possible, and the patient transitioned to a safer alternative therapy under the guidance of a maternal fetal medicine specialist.
We also have to be highly vigilant regarding drug interactions, as the RNI fundamentally alters kidney hemodynamics. We already explored how over-the-counter NSAIDs act on the afferent arteriole to drop renal blood flow and cause fluid retention. But when you actively combine NSAIDs with an RNI, the danger multiplies exponentially.
Because you're attacking the kidney's perfusion from two opposing sides simultaneously.
Exactly. The NSAID aggressively constricts the afferent arteriole, which is the blood vessel feeding into the glomerulus of the kidney. This drops the incoming pressure. Meanwhile, the ARB component of the RNA, the valsartan, blocks angiotensin II, which normally constricts the efferent arteriole, the vessel leading out of the kidney. By blocking that constriction, the ARB aggressively dilates the exit vessel.
So you've choked off the inflow and you've wide open the outflow. The hydrostatic pressure inside the glomerulus essentially drops to zero. The kidney completely loses its ability to filter the blood, and the patient goes into sudden, acute renal failure. This is especially dangerous in older adults or patients who are already volume depleted from heavy diuretic use.
Precisely. You essentially starve the kidney of the pressure it needs to function. Providers also must monitor closely for lithium toxicity. Because the ARNI reduces sodium reabsorption in the proximal tubule, the kidneys predictably attempt to compensate by reabsorbing other similar molecules, and they frequently mistake lithium for sodium. They reabsorb the lithium, causing blood levels to spike into the toxic range, leading to severe neurological symptoms like tremors, ataxia, and seizures.
And there's a very specific, often overlooked dietary note regarding the metabolism of the ARNI. Patients must strictly avoid grapefruit juice and the herbal supplement St. John's wort.
This brings us back to the liver enzymes. Grapefruit juice contains compounds called furanocoumarins, which are highly potent, irreversible inhibitors of the CYP3A4 enzyme system in the liver and the intestinal wall. While the primary metabolic clearance of sacubitril valsartan does not rely solely on CYP3A4, heart failure patients are virtually never on just one drug. They're usually on a massive cocktail of concurrent cardiac medications, statins, antiarrhythmics, calcium channel blockers, that absolutely require CYP3A4 for clearance.
If the grapefruit juice destroys that enzyme, those other medications accumulate to massive, highly toxic levels in the blood, altering their absorption and clearance completely unpredictably. You could trigger a fatal arrhythmia or severe muscle breakdown just from a glass of juice. It's an absolute minefield of interactions, which is why meticulous, continuous reconciliation of every single prescription medication, over-the-counter supplement, and even daily dietary habits is so incredibly crucial for these patients.
It requires a highly coordinated multidisciplinary approach to keep them safe. But let's smoothly transition our focus. We spent a lot of time on the ARNI, and deservedly so, as it is the pinnacle of modern GDMT. But the reality of practice is that not every single patient can tolerate an ARNI. Perhaps their blood pressure is too soft. Perhaps they have a history of angioedema. Or, very frequently in the current healthcare system, their insurance simply refuses to cover the cost of the drug. We must discuss the traditional foundational pillars of GDMT, the old guard, that have been successfully modifying the disease and saving lives for decades.
The adjuvant therapies.
Right.
If a patient cannot safely take the sacubitril valsartan complex, the guidelines dictate that we fall back to our foundational RAAS blockers to achieve that neurohormonal blockade. We start with the classic ACE inhibitors.
The prototype here is enalapril, or the ubiquitous lisinopril. Their mechanism is straightforward but powerful. They competitively bind to and inhibit the angiotensin-converting enzyme in the lungs and kidneys. This completely blocks the enzymatic conversion of the relatively inactive precursor, angiotensin I, into the highly potent destructive vasoconstrictor, angiotensin II. By removing angiotensin II from the equation, we promote systemic arterial vasodilation, which significantly decreases the afterload the heart has to pump against. It also directly suppresses the downstream secretion of aldosterone from the adrenal cortex, which halts the maladaptive retention of sodium in water, reducing the preload.
And if the patient cannot tolerate the ACE inhibitor, usually because the accumulation of bradykinin triggers that severe, relentless hacking cough we discussed earlier, we execute a lateral move and transition them to an ARB, an angiotensin II receptor blocker, like losartan or valsartan alone. The ARB achieves the exact same physiological end goal of vasodilation and reduced fluid retention, but it bypasses the ACE enzyme entirely and simply blocks the angiotensin second molecule from binding to its target receptors on the cells. Because it doesn't inhibit the ACE enzyme, bradykinin is broken down normally and the patient doesn't get the cough.
Those are the vasodilatory pillars. But the real heavy hitter in the old card, the drug class that fundamentally revolutionized how we view the actual cellular progression of heart failure, is the beta-adrenergic blockers.
Okay, stop right there. This is where I always have to throw the brakes on when I'm teaching, and I need to push back on behalf of every single nursing or medical student who has ever looked at the heart failure guidelines in absolute utter confusion. We are talking about drugs like metoprolol succinate, bisoprolol, and carvedilol. These are beta blockers. Their entire specific pharmacological job is to antagonize and block the beta-1 adrenergic receptors located on the myocardial cells of the heart. When you block those receptors, you slow the heart rate down significantly, and you directly decrease the force of myocardial contractility. They are negative inotropes.
That's exactly their mechanism of action.
Right. But we just spent the first 30 minutes of this discussion establishing that in HFrEF, the heart is already failing. It's a weak, flabby, exhausted rubber band that cannot generate enough force to pump adequate blood to the brain and kidneys. The cardiac output is in the gutter. Why on earth would the international gold standard guideline-directed therapy involve intentionally giving a patient a drug that deliberately slows down an already failing heart and chemically makes it squeeze even weaker? Isn't that totally inherently counterintuitive? It sounds like we are actively trying to kill the patient by finishing off what little pump function they have left.
It is the ultimate mind-bending paradox of cardiovascular pharmacology, and your pushback is completely justified. If you look at the heart purely as an isolated mechanical pump, a piece of plumbing, yes, giving a negative inotrope seems completely backwards and dangerous. And the clinical reality reflects that danger. If you give a high aggressive dose of a beta blocker to a patient who is currently in acute decompensated wet heart failure in the ICU, you will absolutely crash their hemodynamics. Their output will plummet, and they will likely require intubation.
So, given that danger, why do we use them so universally in chronic management?
Because, as we established, chronic heart failure is not just a mechanical problem, it's a profound neurohormonal toxicity problem. We have to go back to that sympathetic nervous system response. When the cardiac output initially drops, the body panics. The baroreceptors fire, the brain activates the fight-or-flight response, and the adrenal glands flood the bloodstream and the cardiac tissue with massive, sustained amounts of catecholamines, specifically epinephrine and norepinephrine. The nervous system is constantly, relentlessly whipping the failing heart, screaming at the beta receptors to beat faster, squeeze harder, do not stop.
It's like mercilessly whipping an exhausted, dying horse pulling a heavy cart up a hill.
That is exactly what it is. In the short term, that sympathetic whipping works. It forces the exhausted muscle to work harder, and it temporarily keeps the cardiac output up enough to keep the patient alive. But in the long term, that constant, unending bombardment of toxic catecholamines is devastatingly lethal to the myocardial cells. The high levels of epinephrine cause widespread oxidative stress, inflammation, and programmed cell death apoptosis within the heart muscle. The muscle fibers literally tear themselves apart from the forced overexertion. And this toxic soup triggers a structural process called ventricular remodeling.
Ventricular remodeling. The text explicitly defines this process. It's the progressive dilation and hypertrophy of the ventricles. A normal, healthy left ventricle is shaped like a football and ellipse. That shape is highly efficient for forcefully wringing blood out during systole. But under the constant toxic assault of catecholamines, the collagen matrix of the heart breaks down. The ventricle balloons out. It loses its elliptical shape and remodels into a large, weak, flabby sphere. A basketball shape.
And a spherical ventricle is mechanically disastrous. It cannot generate forward wall tension. The ejection fraction plummets further. Furthermore, that chronic catecholamine toxicity makes the surviving heart muscle incredibly irritable electrically. The resting membrane potentials are constantly skewed, making the patient highly susceptible to sudden, uncoordinated, fatal ventricular arrhythmias like ventricular fibrillation. The patient just drops dead.
So the beta blockers aren't there to help the heart pump more blood today. They aren't trying to improve this minute's cardiac output.
Not at all. The beta blockers are deployed purely as a biochemical shield. The drug molecules sit firmly on those beta-1 receptors and completely block the toxic, relentless pounding of the sympathetic nervous system. They block the epinephrine from binding. They forcibly slow the heart rate down, and they artificially reduce the workload. They force the exhausted, dying horse to finally stop and rest, regardless of the body's panic signals. And what researchers discovered when they studied this long-term is nothing short of miraculous. Over months and years of being consistently shielded by a beta blocker, that destructive ventricular remodeling actually halts. And in many cases, it reverses.
The heart physically heals itself.
It does. Because the toxic assault is blocked, the inflammation subsides. The spherical balloon ventricle gradually shrinks back down. It remodels backward, returning closer toward that normal, efficient elliptical shape. And as the shape improves, the ejection fraction actually slowly begins to rise. By forcing the heart to rest today, we save its architecture for tomorrow. This mechanism is exactly why specific beta blockers, bisoprolol, carvedilol, and sustained-release metoprolol succinate are the absolute bedrock cornerstones of chronic therapy. They have been proven to dramatically, unequivocally reduce overall mortality and vastly reduce the risk of sudden cardiac death from arrhythmias.
It makes complete sense when you zoom out and look at the long game of cellular preservation. But because these drugs are actively suppressing that massive underlying sympathetic drive, there is a severe FDA black box warning regarding their discontinuation.
Yes, the warning against abrupt withdrawal. It requires meticulous clinical management.
Think about the cellular adaptation. If a patient has been faithfully taking a high dose of carvedilol for 2 years, their beta receptors have been constantly blocked. The body, sensing this blockade and desperate to get its sympathetic signals through, has actually undergone a process called upregulation. The heart muscle has literally grown millions of new extra beta receptors to try and catch whatever tiny fraction of epinephrine might be slipping past the drug blockade. The heart is hypersensitized, just waiting for a signal. If the patient suddenly runs out of their medication or decides to stop taking it cold turkey because it makes them feel fatigued, all of those millions of newly grown, completely unshielded receptors are suddenly instantly exposed to the body's massive baseline levels of circulating epinephrine.
It is an instantaneous, massive biochemical shock to the system. The heart rate instantly shoots through the roof into severe tachycardia. The myocardial oxygen demand skyrockets far beyond what the diseased coronary arteries can supply, and the patient plunges into acute severe ischemia. They experience massive, crushing angina. They frequently trigger severe ventricular dysrhythmias, or they sustain a full-blown, massive myocardial infarction.
You can literally cause a fatal heart attack just by abruptly stopping the medication meant to prevent one. If a patient ever needs to discontinue a beta blocker, it must be tapered down incredibly slowly over weeks under strict medical supervision to allow the body time to downregulate and remove those extra receptors safely.
It's a delicate chemical tether. So that represents the chronic long-term ambulatory management. We are meticulously shielding the heart with beta blockers, blocking the destructive RAAS and boosting natriuretic peptides with the ARNI, and slowly reversing the physical remodeling of the ventricle. We are playing the long game. But the harsh reality of this disease is that the long game sometimes fails. What happens when the chronic plan falls apart? This necessitates our transition to exploring acute decompensation, the bridge therapies.
This is the intensive care unit scenario. The patient comes crashing through the doors of the emergency department. Their skin is gray. They are cold and clammy to the touch because their peripheral perfusion has shut down entirely. Their lungs are completely filled with frothy fluid. They are gasping for air, and their cardiac output has essentially collapsed. Their blood pressure is sitting at 70/40. The oral GDMT pills they take at home are entirely useless right now because their gut isn't perfusing enough to absorb them. Even the potent intravenous diuretics and vasodilators we usually rely on aren't enough to maintain cerebral or renal perfusion. The pump is fundamentally failing in real time. We need a bridge.
And it is crucial to define what we mean by a bridge. We are not attempting to cure them in this moment. We are utilizing extremely potent, high-risk pharmacology to artificially force the heart to pump, just to keep their vital organs alive until a definitive intervention can occur. That intervention could mean bridging them to a heart transplant, if they are a candidate. It could mean bridging them to the surgical implantation of a mechanical circulatory support device, like an LVAD, a left ventricular assist device, which is a mechanical pump implanted in their chest. Or, in devastating cases where no surgical options remain, it is a bridge to palliative care, using the drug simply for end-of-life symptom control to allow them to breathe more comfortably. When they are acutely crashing like this, we turn to a specific class of intravenous drugs called phosphodiesterase inhibitors.
The absolute prototype in this class is milrinone. And as a nurse who has spent a significant amount of time in critical care, I have spent countless hours intensely monitoring patients on continuous milrinone drips. It is a profoundly powerful intravenous positive inotropic agent. It forces the heart to beat harder.
Let's delve deep into the cellular mechanism, because it's fascinating how it achieves this positive inotropy completely differently from our traditional sympathetic standbys like intravenous epinephrine or dobutamine, which just hammer the beta receptors. Milrinone bypasses the receptor entirely. It crosses the cell membrane and directly inhibits a specific intracellular enzyme called phosphodiesterase type 3, or PDE3. Normally, the sole job of PDE3 is to break down and clear away a vital secondary messenger molecule called cyclic adenosine monophosphate, or CANMP.
Okay, so by aggressively inhibiting the enzyme that is supposed to break it down, milrinone causes the levels of CAMP to massively surge and accumulate inside the cells.
Exactly. And this is where the pharmacology becomes brilliant, because that surge of CAMP has two completely different yet highly synergistic physiological effects depending on which specific tissue bed the CAMP is accumulating in. Inside the myocardial cells of the heart, that massive increase in CAMP acts as a key to open specific voltage-gated calcium channels on the cell membrane. A massive sudden influx of calcium rushes from the extracellular space into the cell.
And calcium is the essential trigger for muscle contraction.
Precisely. That flood of calcium causes the actin and myosin protein filaments inside the sarcomere to bind much tighter together and pull against each other with vastly greater force. It creates a massive immediate increase in the force of ventricular contraction, a huge positive inotropic effect.
To go back to our earlier analogy, it grabs that weak, flabby, stretched out rubber band, and it artificially, chemically forces it to snap back hard.
Right. It forces forward flow. But here is the secondary magic of milrinone. In the vascular, smooth muscle cells that line the peripheral blood vessels, that exact same accumulation of CAMP triggers a completely opposite reaction. In smooth muscle, CAMP activates a pathway that rapidly sequesters calcium away, hiding it in the sarcoplasmic reticulum and pushing it out of the cell. Without intracellular calcium, the smooth muscle cannot contract. It completely relaxes, leading to profound systemic vasodilation.
So it's actively attacking the failing pump problem from both sides simultaneously. It's forcing the heart muscle to pump significantly harder, generating more output, while at the exact same time, it's opening up all the peripheral blood vessels so that the struggling heart doesn't have to push against any systemic resistance. It drops the afterload to near zero, and it pools blood in the venous system, dropping the preload. We frequently refer to milrinone in the ICU as an inodilator for that exact reason, inotropy plus vasodilation.
It is incredibly effective at immediately rapidly boosting cardiac index and restoring tissue perfusion. And because its mechanism completely bypasses the beta-1 receptors, you can effectively use it even in patients whose beta receptors are completely blocked by their chronic carvedal therapy. It sneaks through the back door of the cell. But, and we must emphasize this heavily, there is a devastating inherent catch to this mechanism.
And this is where I have to push back hard on the utility of this drug. We've established that chronic heart failure guidelines strictly forbid positive inotropes because whipping the heart causes remodeling and death. Yet here we are in the ICU, intentionally giving a massively potent positive inotrope. The clinical trials clearly show that routine short-term use of milrinone actually actively increases overall mortality. We are utilizing a drug that we know statistically kills people faster. How do we justify that at the bedside?
We justify it because the alternative is immediate cardiogenic shock and death. You are entirely correct. The long-term data is grim. We used to believe decades ago this drug makes the heart pump beautifully on the monitor, the patient looks pink and warm, let's give it to everyone with heart failure to make them feel better. But the Massive Promise trial and others showed definitively that if you use milrinone routinely, outside of a crashing scenario, patients die at a much higher rate.
Because we are recreating the exact catecholamine toxicity we use beta blockers to prevent.
Exactly, but via a different pathway. And the immediate cause of that mortality lies in that massive calcium influx we discussed. Flooding the damaged ischemic myocardial cells with massive amounts of calcium forces them to beat harder, yes, but it also makes their electrical conduction system wildly, dangerously unstable. The resting potential is ruined. The most serious immediate adverse effect of milrinone therapy is the sudden development of potentially fatal ventricular dysrhythmias. The source text notes this lethal complication occurs in a staggering 12 to 14% of patients receiving the drug.
That is an immense risk profile. More than 1 in 10 patients receiving this drip might suddenly develop a lethal, pulseless heart rhythm ventricular tachycardia or fibrillation triggered directly by the exact drug we are administering to try and save their life. We are walking an incredibly fine line between restoring perfusion and triggering sudden cardiac death.
Which is exactly why the guidelines are so strict. Milrinone is absolutely restricted to being an intermediate or short-term bridge therapy. utilized exclusively in the highly controlled environment of an intensive care unit. You absolutely do not prescribe this, put the patient in a wheelchair, and send them home on an oral version to take with breakfast. They require continuous, uninterrupted telemetry monitoring of their cardiac rhythm, and usually an invasive arterial line to monitor their blood pressure beat to beat, because that profound vasodilation can sometimes cause their pressure to bottom out completely.
And from the nursing educator perspective, managing this drug at the bedside is a high-wire act with very specific physical constraints. I have to share a vital, practical safety alert regarding the physical intravenous administration of milrinone.
The infamous compatibility issue.
Yes. These crashing patients in the ICU are, by definition, massively overloaded with fluid. They are drowning, so they're almost universally prescribed concomitant high-dose intravenous furosemide, or Lasix, to force profound, rapid diuresis and pull the fluid out of their lungs. But milrinone and IV furosemide absolutely, under no circumstances, can be administered through the same intravenous tubing line simultaneously.
Because of the chemical properties of the two solutions.
Yeah.
What physically happens if they mix in the line?
They undergo an immediate, aggressive chemical reaction based on their pH differences and instantly form a thick, solid precipitate. Visually, it looks like white snow or crystals literally forming inside the clear plastic IV tubing. If you fail to notice that, and that solid precipitate gets flushed into the patient's central venous bloodstream, it acts like a massive shower of microemboli. Those crystals will travel straight to the pulmonary bed or the brain, physically blocking the microscopic capillaries, causing pulmonary infarcts or multiple tiny strokes. You must have dedicated, entirely separate central IV lines for these drugs, or you must meticulously, aggressively flush the shared line with normal saline before and after every single administration.
It highlights how pharmacological safety isn't just about understanding the receptor, it's about understanding the physical chemistry of the delivery. We also have to continuously monitor their lab values, specifically their platelet counts. Milrinone carries a well-documented risk of inducing thrombocytopenia, a severe, rapid drop in the number of circulating blood platelets. This puts the already critically ill patient at a significant risk for spontaneous, uncontrolled internal bleeding. We draw a baseline complete blood count before initiating the drip and monitor constantly during therapy.
The ICU management is intense. It's a minute-by-minute titration, balancing that desperately required forward cardiac output against the ever-present risk of lethal arrhythmias, severe hypotension, and spontaneous bleeding. It is a true bridge over dangerous waters. But let's smoothly transition our focus away from the acute, chaotic, crashing patient in the ICU. Let's move back out to the ambulatory clinic, back to chronic management, and explore some of the newest, most innovative tools in our pharmacological arsenal. We're going to look at two fascinating, highly specific drug classes that have revolutionized recent heart failure guidelines because of their targeted precision or their unexpected serendipity.
The first innovation we will examine is a drug class where there is currently only one single FDA-approved drug available on the market, the sinoatrial node modulators. The drug is ivabradine, known by the brand name Corlinor.
I love discussing ivabradine because it solves a very specific, frustrating clinical dilemma that providers face all the time. We established at length that beta blockers save lives by shielding the heart, lowering the oxygen demand, and specifically by keeping the resting heart rate low. The target resting heart rate for a heart failure patient is usually around 50 to 60 beats per minute. But what happens when you have a patient who is already taking the maximum, completely maxed out tolerated dose of their beta blocker, say? They are on a massive dose of carvedilol, and if you give them even 1 more milligram, their blood pressure will crash into the floor. But despite that massive dose, their resting heart rate is stubbornly stuck above 70 or 75 beats per minute.
That persistently high resting heart rate is a massive clinical problem. A heart rate of 75 might be normal for a healthy person, but for failing ventricle, every extra beat is burning precious, limited oxygen. It's exhausting the muscle. We desperately need to slow that heart rate down further to allow for better diastolic filling time and reduced workload, but we are completely paralyzed because we cannot safely utilize any more beta blockers without causing severe hypotension. That specific, narrow clinical window is exactly where ivabradine proves its value.
How does it manage to slow the heart down without acting like a beta blocker and crashing the blood pressure?
It achieves this through beautifully targeted, microscopic precision. Ivabradine bypasses the sympathetic nervous system entirely. It travels straight to the sinoatrial node, the SA node, which is the specialized cluster of cells in the right atrium that acts as the natural intrinsic electrical pacemaker of the heart. Inside the membrane of those specific SA node pacemaker cells, there are highly specialized ion channels called hyperpolarization activated cyclic nucleotide gated channels. In electrophysiology, they're affectionately known as the funny channels, or F channels.
They're called funny channels because they behave completely differently, almost paradoxically, compared to typical voltage-gated sodium or potassium channels in the rest of the body.
Precisely. Most channels open when a cell depolarizes. Funny channels open when the cell hyperpolarizes, when the electrical charge drops. Their sole physiological purpose is to allow a slow, steady, continuous inward leak of sodium ions into the pacemaker cell. This slow leak gradually, predictably, raises the internal electrical charge until it hits a specific threshold, triggering the cell to fire an electrical impulse. The speed of that inward sodium leak directly solely determines how fast the SA node fires, which determines your heart rate. Abrams specifically selectively binds to the inside of these funny channels and physically blocks the pore, restricting that inward flow of sodium.
So if the sodium is leaking in much slower, it takes significantly longer for the cell's internal electrical charge to reach that firing threshold.
Exactly. It prolongs the phase of spontaneous diastolic depolarization. The firing rate of the SA node slows down smoothly, and consequently, the overall heart rate drops. But, and this is the absolutely crucial distinction from beta blockers, because these specific funny channels essentially only exist in significant numbers within the SA node itself, ivabradine has absolutely zero pharmacological effect on the actual working myocardial muscle cells of the ventricles, and it has no effect on the smooth muscle of the blood vessels.
That is the brilliance of it. It selectively, cleanly drops the heart rate and the oxygen demand, but it completely avoids weakening the force of the systolic squeeze, and it doesn't drop the blood pressure. It is indicated specifically to reduce the risk of hospitalization for worsening heart failure in these very specific, stable, symptomatic patients who have an ejection fraction of 35% or less, who are in normal sinus rhythm, and whose heart rate remains at or above 70 despite maximally tolerated beta blockade. But because it works on such a specific, unusual ion channel, it carries some highly specific, deeply unusual side effects.
You are referring to the visual disturbances.
Yes, the phosphanes. This is one of the wildest adverse effects in cardiology. Because, as it turns out, there are ion channels located deep in the retina of the human eye that are structurally and genetically very, very similar to the funny channels in the cardiac SA node. Because the drug isn't perfectly selective, ivabradine accidentally binds to and blocks those retinal channels as well. As a result, patients experience phosphenes, which our text defines as intermittent, transient phenomena of enhanced brightness in a limited area of the visual field.
Patients will describe seeing sudden, unexplained stroboscopic flashes of bright light, or perceiving luminous halos around objects, or experiencing multiple overlapping images. It is completely painless but incredibly disorienting.
It's a dose-dependent effect, meaning it usually happens when the drug peaks in their system, and it typically resolves on its own over a few months as the body adjusts. But we absolutely must warn patients about this before they take their first dose, particularly regarding driving a vehicle at night. Imagine driving 65 miles an hour down a dark highway, and suddenly the headlights of oncoming cars fracture into massive, blinding halos or multiple flashing images. It could be catastrophic. They need to know to expect it and to adjust their driving habits accordingly.
We also have to be incredibly meticulous with how the patient physically ingests the medication, as its pharmacokinetics are highly unusual. Ivabradine absolutely must be taken with meals.
Food usually slows down the absorption of most drugs, which we usually want to avoid.
Right, taking ivabradine with food does delay the initial absorption time, but paradoxically, the presence of food in the digestive tract actually increases the total overall systemic plasma exposure to the active drug by roughly 20 to 40%. Taking it with a meal ensures a consistent, predictable, extended pharmacological action in the body, preventing dangerous spikes and troughs in their heart rate.
And we cannot discuss a new oral cardiac drug without bringing up its metabolic pathway, which is heavily reliant on our old friend, the liver enzyme CYP3A4.
Which inevitably brings us right back to the grapefruit juice warning. Patients absolutely unequivocally cannot consume grapefruit juice while taking ivabradine. As we discussed, grapefruit juice irreversibly destroys the CYP3A4 enzyme in the gut and liver. Without that enzyme actively breaking down the drug, the ivabradine continues to absorb and accumulates to massive toxic levels in the blood plasma.
It blocks entirely too many of those funny channels in the SA node.
Exactly. The SA node firing slows to a crawl, leading to severe life-threatening bradycardia, a heart rate that is dangerously profoundly slow, potentially leading to syncope, hemodynamic collapse, or cardiac arrest. The dietary restrictions are literal lifesavers.
Okay, so that is the targeted precision of ivabradine. Now, let's pivot to look at the absolute wild card of modern heart failure innovations. The drug class that no one saw coming, the SGLT2 inhibitors. We are talking about medications like dapagliflozin and pagliflozin and canagliflozin. In clinical parlance, we just call them the flozin.
The story of the SGLT2 inhibitors is genuinely one of the most exciting, serendipitous developments in the entire history of modern pharmacology. We have to understand their origin. These drugs were engineered, tested, and originally FDA approved strictly and exclusively as oral hypoglycemic agents for the management of type 2 diabetes. They had absolutely nothing to do with cardiology.
Right. SGLT2 stands for sodium glucose cotransporter 2. This is a highly specialized transport protein located abundantly in the proximal convoluted tubule of the nephrons in the kidneys. Normally, as your kidneys filter your blood, they filter out a massive amount of free glucose. But the body doesn't want to waste that valuable energy source. So the SGLT2 protein's specific job is to actively grab that filtered glucose out of the early urine and reabsorb it back into the bloodstream. In a healthy person, it reabsorbs 100% of the filtered glucose.
So the mechanism of an SGLT2 inhibitor is beautifully simple. It binds to and completely blocks that transport protein. The kidney can no longer reabsorb the glucose. So all of that excess glucose simply remains in the renal tubules and spills out into the final urine. It's an incredibly effective, straightforward way to lower circulating blood sugar levels in type 2 diabetics. You literally pee the excess sugar away down the toilet.
It works wonderfully for diabetes, but here's where the story gets fascinating. Because of some previous high-profile scandals with older diabetes medications causing heart attacks, the FDA mandated that all new diabetes drugs must undergo massive long-term cardiovascular outcome trials just to prove they don't actively harm the heart. So they put tens of thousands of diabetics on these flozins and watched them for years.
And when the independent researchers unblinded the trial data, they were absolutely stunned. The diabetic patients taking the SGLT2 inhibitors weren't just experiencing better glycemic control, their rates of developing heart failure and their rates of being hospitalized for acute heart failure exacerbations were plummeting. The curve separated massively very early in the trials.
It was this massive, completely unexpected secondary benefit. The cardiology world scrambled to figure out why a diabetes drug was fixing the heart better than some actual cardiac drugs. The exact, complete microscopic mechanism is still being intensely unraveled and debated, but we know the primary driver comes down to the mechanics of osmotic diuresis.
Exactly. Remember the fundamental rule of renal physiology. Water inevitably follows solutes. Because the drug is forcing the kidneys to dump massive amounts of highly concentrated glucose into the urine, that glucose acts as an osmotic magnet. It pulls and traps a massive volume of water and sodium inside the tubule with it. This promotes a profound, continuous state of natriuresis and diuresis.
But it's a different kind of diuresis than our standard loop diuretics. Loop diuretics aggressively pull fluid from the intravascular space, the blood vessels, which can cause dangerous drops in blood pressure. The SGLT2 inhibitors seem to preferentially pull fluid from the interstitial space, the tissues where the actual edema and swelling reside, while largely preserving the intravascular volume. It gently, constantly drops the overall fluid volume, which permanently drops the preload, taking a massive, continuous mechanical strain off the failing, stretched-out ventricle.
Furthermore, they appear to alter myocardial metabolism, forcing the failing heart to switch from burning free fatty acids to burning ketones, which is a much more oxygen-efficient fuel source for a struggling muscle. They also exert a profound, direct protective effect on the nephrons themselves, significantly reducing the progression of chronic kidney disease. And the true paradigm shift, the moment these drugs completely rewrote the textbooks, happened when researchers asked the obvious next question: do you actually need to have diabetes to get these cardiac benefits?
And the answer was a resounding no. Multiple massive landmark trials like DAPA-HF and Emperor Reduced have now definitively demonstrated that SGLT2 inhibitors significantly reduce cardiovascular mortality and drastically reduce hospitalizations for patients with HFrEF, regardless of whether they have type 2 diabetes or completely normal blood sugar.
They underwent an unprecedented transformation. They went from being categorized as diabetes drugs with a nice cardiac side benefit to being immediately elevated to frontline, foundational, guideline-directed heart failure heroes. They are now considered one of the 4 essential pillars of HFrEF therapy, alongside the ARNI, beta blockers, and MRAs.
Of course, we still have to monitor them carefully. Because they are forcing glucose and water out, we must assess the patient for signs of significant volume depletion or orthostatic hypotension, especially if they are taking them alongside traditional loop diuretics. We also must educate them on the increased risk of genitourinary infections because you are constantly coating the urinary tract, and sugar-rich urine, yeast infections, and UTIs become significantly more common. And while the risk of true hypoglycemia is actually very low if they don't have diabetes, we still educate them on the signs. And crucially, we meticulously track their GFR, their glomerular filtration rate, through routine blood work to ensure their kidney function remains stable, although these drugs usually protect the kidney in the long run.
The SGLT2 inhibitors perfectly, elegantly illustrate how deeply intertwined our physiological systems are. Fixing a transport protein in the kidney profoundly heals the architecture of the heart, which serves as the perfect natural bridge to the final critical component of our deep dive. We've talked extensively about the sophisticated, elegant neurohormonal blockers, the genetic shielding, and the targeted modulators. But we absolutely cannot forget the everyday, grinding, mechanical reality of chronic heart failure management.
Fluid management. It's the unglamorous daily trench warfare of the disease. At the end of the day, regardless of how perfectly optimized their AR9 or beta blocker dose is, if the patient is acutely drowning in 5 liters of retained fluid, their neurohormonal blockade will not save them from asphyxiating. You have to get the fluid off. And for that mechanical clearance, we rely on the classic foundational diuretics. The text outlines 3 main classes utilized heavily in heart failure, each targeting a different segment of the nephron: loop diuretics, thiazide diuretics, and aldosterone antagonists.
Let's begin with the heavy artillery, the loop diuretics. The absolute standard prototype here is furosemide, universally known as Lasix. It exerts its action deep in the renal medulla, specifically targeting the thick ascending limb of the loop of Henle. This segment of the nephron is normally responsible for reabsorbing a massive portion of the filtered sodium back into the blood. Furosemide binds to and completely blocks the NAK2Cl importer protein. It halts the reabsorption of sodium, chloride, and potassium. And because water inherently follows salt, it traps a massive volume of water in the tubule, causing a profound, rapid, torrential diuresis.
This is the exact tool we reach for when a patient is in the ER in acute, life-threatening fluid overload. We give them IV Lasix, and they can produce liters of urine in a matter of hours. The fluid pulls off the lungs, and they can finally breathe. But loop diuretics are biologically indiscriminate. They do not just dump water and sodium, they aggressively waste everything, particularly potassium.
And that profound potassium wasting, that iatrogenic hypokalemia, is a massive systemic liability that frequently triggers lethal arrhythmias, as we will explore in detail momentarily. Then we have the thiazide diuretics, represented by drugs like hydrochlorothiazide, or HCTZ. They operate further downstream in the nephron, specifically in the early distal convoluted tubule. They are much milder in their action. They inhibit the sodium chloride symporter, blocking a smaller percentage of sodium reabsorption. They do not produce the torrential, rapid urine output of a loop diuretic.
Thiazides are generally preferred for patients who primarily suffer from systemic hypertension and perhaps only have mild chronic fluid congestion. They are excellent antihypertensives, but they are relatively weak diuretics for severely overloaded heart failure patient. And importantly, just like the loops, thiazides are heavily potassium wasting. They actively deplete the body's potassium stores.
Which leads us to the final and most structurally important class of diuretics, the aldosterone antagonists, also known as mineralocorticoid receptor antagonists, or MRAs. The primary drugs here are spironolactone and eplerenone.
Now, these are entirely unique in their mechanism and their purpose.
Very unique. They exert their effects at the very end of the nephron line, in the late distal tubule and the collecting duct. They directly competitively block the intracellular receptors for the hormone aldosterone. Remember our discussion of the RAES pathway? Aldosterone is the final hormone that instructs the kidney to actively hold on to sodium and excrete potassium into the urine. By blocking the aldosterone receptors, spironolactone reverses that order. It tells the kidney to excrete sodium and water and to actively hold on to potassium. They're classified as potassium-sparing diuretics.
But here's the critical distinction we must make for clinical practice. In the context of heart failure with reduced ejection fraction, we are not primarily utilizing spironolactone just to make the patient urinate. Its diuretic effect is actually incredibly weak compared to Lasix. Spironolactone is utilized because it's the final missing piece of that neurohormonal blockade we discussed in GDMT. High chronic levels of circulating aldosterone do much more than just retain fluid. Aldosterone directly binds to receptors on the fibroblasts inside the heart muscle itself.
Exactly. Aldosterone directly stimulates those fibroblasts to aggressively overproduce collagen, leading to widespread interstitial fibrosis, thick, rigid scarring throughout the myocardium. It turns the heart muscle into stiff, inflexible scar tissue.
That fibrosis makes the heart rigid, severely worsens that diastolic stiffness we see in HFpEF, and creates physical barriers that disrupt electrical pathways, making the heart incredibly prone to lethal dysrhythmias. By blocking the aldosterone receptors with spironolactone, we physically prevent that fibrotic scarring from occurring. We preserve the suppleness of the remaining healthy muscle. This is why MRAs are a mandatory pillar of GDMT. They dramatically improve long-term systolic function and definitively reduce mortality.
They are disease-modifying agents, not just symptom relievers. However, because they actively instruct the kidney to hoard potassium, and because they are almost always prescribed alongside an ARNA or an ACE inhibitor, which also inherently raise potassium levels, we must meticulously monitor the patient for hyperkalemia. Too much potassium is just as lethal as too little, causing profound electrical blocks in the heart, resulting in asystole.
And from a nursing and patient education perspective, managing a patient on this complex cocktail of varying diuretics requires extreme vigilance regarding their daily fluid status. In the hospital setting, we monitor strict intake and output. We measure every milliliter they drink and every milliliter they excrete, but the absolute gold standard, the most reliable metric for tracking fluid status, both in the hospital and at home, is the daily weight. We mandate that the patient weigh themselves every single morning on the exact same scale, wearing the exact same amount of clothing, immediately after they void their bladder before they eat or drink anything.
The physics behind this are infallible. 1 liter of retained fluid weighs exactly 1 kilogram, or 2.2 pounds.
Right. It is physically impossible to gain 3 pounds of actual adipose fat or muscle tissue overnight. So, if a patient records their weight and they have gained more than 2 pounds in a single 24-hour period, or more than 5 pounds over the course of a week, that weight is not fat. That weight is pure retained water. That is a massive objective red flag that their compensatory mechanisms are failing, their current diuretic dose is inadequate, and they are actively decompensating. They need to alert their provider immediately so we can preemptively double their oral diuretic dose at home before that fluid backs up into their lungs and they end up in the emergency room gasping for air. Daily weights save lives.
And while we are carefully balancing all these fluid volumes, managing blood pressure, and trying to protect the kidneys, we have to dedicate time to discussing one of the oldest, most notorious, and most pharmacologically complex drugs in our entire cardiovascular arsenal, digoxin.
Digoxin, brand name Lanoxin. The history of this drug is utterly fascinating. It is ancient by medical standards. It's literally a purified cardiac glycoside extracted directly from the leaves of the foxglove plant, Digitalis lanata. People were boiling the leaves and making teas out of foxglove centuries ago, long before we understood the heart, to treat a condition they called dropsy, which was the historical term for the massive, full-body fluid swelling caused by end-stage heart failure.
It is a drug with an incredible legacy, but we must contextualize its current role in modern medicine. Digoxin is absolutely not a first-line therapy anymore. The ARNI, the beta blockers, the SGLT2 inhibitors, the MRAs, all of those modern pillars actually halt the disease process and significantly reduce mortality. They keep people alive longer. Digoxin has been proven definitively to not reduce overall mortality. It does not extend life.
So why is it still in the guidelines? Why do we still prescribe a toxic plant extract?
Because it remains highly effective at improving the quality of life. It is still utilized as an adjuvant therapy because it definitively improves debilitating symptoms, increases exercise tolerance, and significantly reduces the frequency of hospitalizations in patients with severe advanced HFrEF who remain highly symptomatic despite already being maxed out on all the other modern therapies. It is a powerful, positive inotrope. It forces the failing heart to pump harder and more efficiently. But its microscopic mechanism of action is entirely different from the KMP pathway of milrinone. How exactly does a compound from a flower force a stronger myocardial contraction?
It's a brilliant indirect cascade of cellular events. Digoxin acts directly on the outer cell membrane, the sarcolemma of the myocardial cells. Specifically, it targets and physically binds to an essential ubiquitous enzyme pump called the sodium-potassium ATPase pump.
Let's break the normal function of that pump down to understand the disruption. After a cardiac muscle cell successfully fires an action potential and contracts, its internal electrical and chemical environment is chaotic. It has to rapidly reset itself to prepare for the next beat. The NAK-ATPase pump is the primary reset mechanism. It uses cellular energy ATP to aggressively constantly push 3 sodium ions out of the cell and pull 2 potassium ions back into the cell against their concentration gradients, restoring the negative resting electrical baseline.
Digoxin acts as a physical wrench in the gears. It binds to the extracellular face of that pump and completely jams it. It competitively inhibits the pump, stopping it from working. Because the pump is disabled, the sodium that naturally entered the cell during the last contraction cannot be pushed back out. Consequently, the concentration of sodium ions builds up rapidly inside the myocardial cell.
And why does that specific intracellular sodium buildup matter so much for contractility?
Because it fundamentally disrupts a secondary, completely different pump located on the same cell membrane, the sodium-calcium exchanger, or NCX. Normally, this exchanger operates without needing ATP energy. It simply uses the powerful natural flow of sodium wanting to rush into the cell to power a revolving door that forcefully expels calcium out of the cell. It uses the sodium gradient as its power source to clear calcium. But because digoxin has jammed the first pump, causing so much sodium to accumulate inside the cell, that natural concentration gradient is completely ruined. There is no longer a strong desire for sodium to enter. The sodium-calcium exchanger loses its power source, it stalls out, becomes sluggish, and in severe cases, it actually begins to run in reverse.
So the normal mechanism for clearing calcium from the cell is completely paralyzed.
Exactly. Because the calcium cannot be expelled, the intracellular calcium levels rise significantly with every single heartbeat. More and more calcium is sequestered into the sarcoplasmic reticulum. And as we established earlier with mirinone, the fundamental rule of muscle physiology is that more free calcium inside a heart cell means vastly more binding between the actin and myosin filaments. It results in a much stronger, more forceful, and faster mechanical contraction. A profound, positive inotropic effect achieved entirely by manipulating secondary ion gradients.
It is a phenomenal chemical chain reaction. You block the primary potassium pump, which functionally breaks the secondary calcium pump, which artificially forces a much stronger heartbeat. But this complex indirect mechanism brings us to one of the most dangerous, highly monitored safety profiles in all of clinical pharmacology. Digoxin possesses an incredibly narrow therapeutic index.
It is the definition of a high-alert medication. The therapeutic index is the ratio between the dosage that produces the desired beneficial effect and the dosage that causes toxic, potentially lethal harm. With digoxin, that margin is razor thin. A blood level of 0.8 nanograms per milliliter is therapeutic and helpful. A blood level of 2.1 is highly toxic and potentially lethal. The difference is microscopic.
So given that tiny margin of error, what does this actually mean for daily clinical monitoring? Providers and patients must be hypervigilant for the early, subtle signs of digoxin toxicity. And fascinatingly, those early warning signs almost never involve the heart initially. They present as systemic, neurological, and gastrointestinal symptoms long before the lethal cardiac rhythms appear.
Yes, the progression of symptoms is highly predictable. The very first complaint is almost always profound gastrointestinal distress. The patient will complain of severe anorexia. They completely suddenly lose their appetite, even for foods they love. This is rapidly followed by intense waves of nausea and frequent vomiting. If a stable heart failure patient on digoxin suddenly cannot keep their breakfast down, you must immediately suspect toxicity.
If the levels continue to rise, the toxicity breaches the central nervous system. You see profound neurological and visual changes. The patient might experience sudden mental confusion, lethargy, or complain of persistently blurred vision. And then you look for the absolute hallmark, pathognomonic sign of severe digitalis toxicity. Chromatopsia, specifically changes in color perception.
The classic symptom is seeing yellow-green halos surrounding lights. Or they might describe the entire room looking like it has a yellow tint to it, as if they are wearing tinted sunglasses. If a heart failure patient taking digoxin casually mentions to you that the fluorescent lights in the clinic have yellow rings around them, or the television looks green, you do not send them home. You immediately draw a stat serum digoxin blood level, and you immediately get a 12-lead EKG. Because the next phase of the toxicity is cardiac, and it is frequently lethal.
The excess intracellular calcium that we induce to strengthen the squeeze eventually overloads the cell, making the electrical conduction system incredibly unstable and chaotic. Digoxin toxicity can cause virtually every known heart rhythm disturbance, from severe bradycardia and AV blocks to rapid tachycardias. The most common, earliest cardiac sign we observe on the telemetry monitor are PVCs, premature ventricular contractions. The irritable ventricles spontaneously fire an electrical impulse early, completely out of sync with the normal pacemaker.
Patients will frequently feel this mechanically. They'll complain of a sudden skipped heartbeat or a strong, uncomfortable flutter or palpitation in their chest. If left untreated, those PVCs degenerate into ventricular tachycardia and death.
And this brings us to the ultimate, most critical physiological connection of this entire discussion. If we connect the pharmacology of digoxin to the bigger picture of the patient's entire medication regimen, we have to ask, why do so many heart failure patients spontaneously develop life-threatening digoxin toxicity even when their daily dose hasn't changed in years? The answer is almost always found in their diuretic regimen.
It all comes back to the loop and thiazide diuretics,
Yeah.
the furosemide and the hydrochlorothiazide.
Exactly. Remember, we established that those aggressive diuretics rapidly and indiscriminately waste potassium into the urine. They frequently cause severe hypokalemia, low blood potassium. And potassium is the absolute key, the biological governor of digoxin toxicity.
How so? Walk us through that cellular interaction.
Let's go back to the exact mechanism on the cell membrane. Digoxin exerts its effect by physically binding to the sodium-potassium ATPase pump. But it doesn't just bind anywhere, it binds to the exact same specific receptor site on the extracellular face of the pump that the potassium ions must bind to in order to be pulled into the cell. Digoxin and potassium are mutually exclusive. They compete directly against each other for the exact same seat on the pump.
Oh, wow. I never realized it was a direct physical competition for the receptor.
It is a chemical battle for territory. If a patient's serum potassium levels are perfectly normal, there's an abundance of potassium ions floating around in the extracellular fluid to fight off the digoxin molecules. The sheer volume of potassium keeps the digoxin in check, preventing it from binding to too many pumps. The drug remains therapeutic. But if that patient is hypokalemic, if they took an extra dose of Lasix yesterday because their ankles were swollen and they urinated all the protective potassium away, there is suddenly no competition left.
The potassium shield drops and the digoxin molecules simply swarm the unprotected pumps.
Exactly. Without potassium fighting for the seats, every single circulating digoxin molecule easily finds an empty receptor and binds instantly. The blockade of the pumps becomes massive, absolute, and overwhelming. And here is the truly terrifying, counterintuitive part for clinicians. Hypokalemia alters the physical binding affinity of the receptor, making the myocardium vastly more sensitive to the drug. A patient can develop florid, fatal digoxin toxicity, the nausea, the yellow halos, the lethal arrhythmias, even if their actual serum blood levels of the digoxin drug appear perfectly normal on the lab printout.
The raw amount of drug in their blood isn't technically high, but the tissue sensitivity is through the roof because the competitive potassium shield is completely gone.
Precisely. That is why empirically replacing potassium, relentlessly monitoring daily electrolyte lab values, and constantly assessing the patient for those subtle early signs of toxicity, the sudden loss of appetite, the visual halos, the skipped beats on the radial pulse, is quite literally a matter of life and death. You cannot manage a patient on digoxin without simultaneously micromanaging their potassium levels. It is an intricate, highly delicate biochemical balancing act.
It really is. It's a precarious, high-wire act over those muddy waters we discussed at the beginning. And that brings us to the end of an incredibly dense, complex journey through the cardiovascular system. We have traversed the entire contemporary landscape of left ventricular systolic dysfunction. We started by understanding the fundamental physics of the failing pump, distinguishing the stretched, weak, flabby rubber band mechanics of HFrEF from the stiff, unyielding, rigid leather pouch mechanics of HFpEF.
We unpacked the monumental paradigm shift of guideline-directed medical therapy. We saw how we moved from plumbing to neurohormonal warfare. We explored how the ARNI revolution, the elegant combination of sacubitril and valsartan, simultaneously preserves the body's beneficial natriuretic peptides while acting as an impenetrable shield against the harmful fibrotic RIA system, provided we rigorously respect that crucial 36-hour washout period to prevent fatal angioedema.
We discussed the paradoxical, counterintuitive brilliance of the beta blockers, intentionally slowing the heart to shield it from toxic catecholamines, ultimately reversing the physical spherical remodeling of the ventricle over time. We explored the intense, high-stakes, acute rescue of milrinone drips in the ICU, balancing improved contractility against the terrifying risk of fatal arrhythmias. And we looked at the targeted precision of ivabradine, slowing the SA node without weakening the squeeze.
And finally, we navigated the delicate, ever-present, dangerous interplay of fluid diuresis, aldosterone blockade, potassium wasting, and the constant looming threat of digoxin toxicity.
To you, the listener, whether you are heading into a grueling pharmacology final exam tomorrow or you are walking onto the cardiac step-down unit for your next 12-hour shift, I hope this deep dive has fundamentally altered how you view these medications. I hope we have shown you that managing heart failure isn't just about blindly picking a drug off an algorithm or memorizing a standard dosage.
No, it's about clearly seeing the massive interconnected web of human physiology. It is understanding how prescribing a simple loop diuretic profoundly affects the concentration of a single potassium ion, which in turn completely dictates whether a centuries-old extract from a foxglove plant will strengthen a dying heart or fatally stop it. It is understanding the exact enzymatic reason why a simple 36-hour pause between swallowing two different pills could be the only physiological barrier preventing a massive, fatal airway obstruction.
The X-ray machine is broken, it's murky waters, but a deep understanding of pharmacology gives us the sophisticated tools we need to navigate them and actually save lives.
And those pharmacological tools are constantly, rapidly evolving. I want to leave you with a final thought to ponder as we close. We spent time discussing the incredible story of the SGLT2 inhibitors. These are molecules engineered entirely, specifically for the kidneys and the pancreas to manage the glucose levels of diabetes. They were never intended for the heart. Yet, through mandatory observation and scientific curiosity, they ended up completely rewriting global heart failure guidelines, purely through their unexpected systemic physiological effects.
It makes you wonder.
It absolutely makes you wonder, what other established drugs are currently sitting passively on the shelves in our local pharmacies, thoroughly approved for entirely different, seemingly unrelated diseases that might hold the secret to completely reversing ventricular remodeling? What pathways haven't we connected yet? Are we on the verge of discovering that the ultimate definitive pharmacological cure for heart failure is already hiding in plain sight, just waiting for us to notice the pattern in the data?
Now, that is a thought that will stick with you long after your shift ends. The pathology is complex, the mechanisms are delicate, but the potential discoveries are profound. Thank you for joining us on Rounds today. Keep questioning the why behind the mechanisms, keep meticulously protecting your patients from the unseen interactions, and we'll see you on the next deep dive.